Okay, welcome back to CVRESP, everybody. This is the third part of the three-part series for our CVRESP recap. Welcome to week 3. Let's hit the ground running and put a cap on it. So, before we go anywhere near pathology, we need structural control over the volume relationships. Not memorizing definitions, understanding how they all fit together. So think of lung volumes as building blocks. Tidal volume is your normal quiet breath. IRV is what you can still inhale after normal inspiration. ERV is what you can still exhale after normal expiration. And residual volume is what you can never voluntarily exhale. That's the structural floor of the lungs. Now, here's where exam writers like to play games. They don't test those definitions straight up, they test the relationships between them. So, total lung capacity, or TLC, is everything, all four volumes added up together. VC excludes residual volume. That matters clinically. FRC is what's left in the lungs at the end of passive expiration. That's ERV plus RV. IC is what you can inhale from resting state. So that would be IRV plus VT. FRC is especially important because it represents the balance point between lung recoil inward and chest wall recoil outward. That equilibrium concept will come back later when we talk about pulmonary vascular resistance. So memorize the math, but also understand the architecture, and the math will follow. So this slide is just literally first order exam knowledge stuff. So spirometry just measures air that moves in and out of the mouth. That's the rule. If air never leaves the lungs, spirometry cannot measure it. So tidal volume, IRV, ERV, you can use spirometry to measure that. FVC and FEV1, you could also use spirometry for that, but residual volume is impossible because it never truly exists. And if you can't measure residual volume, you cannot directly measure FRC or TLC using spirometry alone, because both of those include residual volume. Any question that implies spirometry gives you residual volume is wrong. So just know that out the gate. To measure RV or FRC, you need body plethysmography. It's a crazy word. It's new for me. Or gas dilution methods, but that's beyond what we're going to be talking about here, and it's not one of our clinical correlates, so fancy medical buzzwords being thrown at you. So now let's integrate. If residual volume increases, what does that mean physiologically? It means air trapping. Air is getting in, but not getting out efficiently. If RV increases, FRC increases, and because TLC includes RV, TLC may increase too. That pattern screams obstructive disease, which it has its own slide and everything. But in obstructive disorders like COPD, airway collapse during expiration traps air. The lungs become hyperinflated, compliance goes up, recoil goes down, patient looks barrel-chested because TLC is elevated. So now let's contrast that with restrictive disease. If TLC is reduced, but RV is normal or even low, that suggests that the problem isn't air trapping, it's inability to expand the lungs. So restrictive lungs are stiff, they can't usually inflate fully, so TLC will then drop, right? If your lungs can't fully inflate, your total lung capacity will diminish. So the pattern recognition here is obstructive means too much air stuck inside, restrictive means can't get enough air in. Okay, so here's out the gate, first thing to know about inspiration. It is active, okay? The diaphragm contracts and moves downward. That increases thoracic volume. Increasing volume decreases intrathoracic pressure. Air flows down the pressure gradient into the lungs. The external intercostals assist by elevating the ribs and expanding the chest wall. Expiration under normal resting conditions is passive. It relies on elastic recoil. That's the stored potential energy in stretched lung tissue. So why does that matter clinically? Because in obstructive disease, recoil is impaired. Expiration becomes active and prolonged. Also, accessory muscle use during quiet breathing is abnormal. So if someone is recruiting sternocleidomastoids or scalene muscles at rest, they are for sure compensating. And a nice little way to remember What the external intercostals do is externals don't exhale, right? They help with inhaling, inspiration. So pretty easy way to remember that there. So compliance is one of the most important conceptual tools in pulmonary physiology. Compliance equals change in volume divided by change in pressure. It's the slope of the pressure volume curve. So high compliance means the lungs inflate easily, but they don't recoil well. Think emphysema, which is inflated lung tissue. So destroyed elastic tissue, which is easy to inflate, hard to empty. Okay. So low compliance means stiff lungs. So think pulmonary fibrosis, hard to inflate, but recoil is strong. So now here's the integration point. So obstructive disease, increase compliance. Restrictive disease, decrease compliance. And compliance directly influences work of breathing. Stiff lungs require high inspiratory effort. Hypercompliant lungs require prolonged expiration. Okay, so Laplace's law says pressure required to keep a sphere open equals 2 times surface tension divided by the radius. So small alveoli require higher pressure to stay open, unless surface tension is reduced. That's where surfactant comes in. Surfactant lowers surface tension, especially in smaller alveoli. That stabilizes them and prevents collapse. Without surfactant, smaller alveoli would collapse into larger ones, a phenomenon called atelectasis. In premature infants, surfactant production is insufficient, so that increases collapsing pressure, causing neonatal respiratory distress syndrome. So surfactant doesn't just reduce work of breathing, it equalizes pressure across alveoli of different sizes. So knowing the reason for surfactant, when it's released, which we got into a bit with the embryology of it in the week 2 video, that's all very high yield for this exam. Okay, so this slide is pretty simple, but, it can get confusing. But laminar flow is smooth and orderly. Pressure and flow are proportional. That's predictable. Turbulent flow is chaotic. Now pressure must increase disproportionately to generate the same flow. So turbulence increases with high velocity, large airway diameter, and high gas density. Large airway diameter might surprise you, but turbulence often occurs in the trachea and main bronchi, not the tiny bronchioles. So clinically, turbulent flow increases the work of breathing. That's why airway obstruction increases effort disproportionately. So laminar flow is efficient, turbulence is costly. Okay, so resistance is inversely proportional to the 4th power of radius. That's not linear, that's exponential. So if airway radius is cut in half, resistance increases 16-fold. That is almost always just a math question, multiple choice question that you will encounter. They will always be like, if you decrease a radius to this much, how much will resistance increase? And it's literally just testing if you know this equation or not. So small degrees of bronchoconstriction cause massive resistance changes, and it's because of this formula, okay? So asthma works exactly this way. Smooth muscle constriction narrows the airway, resistance skyrockets, work of breathing increases. And here's something subtle. More resistance in normal lungs actually resides in larger airways, because although small airways are narrow, they exist in parallel and collectively create a huge total cross-sectional area. So when obstruction affects small airways diffusely, resistance rises dramatically. So this curve is one of the most commonly tested physiologic relationships. Pulmonary vascular resistance follows a U-shaped relationship with lung volume. At low lung volumes, extraalveolar vessels collapse because radial traction is reduced. Resistance increases. At high lung volumes, alveoli expand and compress alveoli capillaries. Resistance increases again. The lowest pulmonary vascular resistance occurs near FRC, the resting equilibrium volume. So, when lungs are overinflated, like in severe emphysema, pulmonary vascular resistance increases. When lungs are severely deflated, resistance also increases. FRC is the sweet spot. Okay, so west lung zones are about pressure relationships. So zone 1, alveoli pressure exceeds arterial pressures. So capillaries collapse, minimal perfusion is occurring. Zone 2, arterial pressure exceeds alveoli pressure, but venous pressure is lower. Flow depends on arterial minus alveolar pressure. And then you have zone 3, which is arterial and venous pressure exceed alveolar pressure. And this this will cause continuous perfusion. Because gravity increases perfusion towards the base of the lung, the apex has relatively less perfusion compared to ventilation. That means high VQ at the apex. Okay, now keep in mind, perfusion is different than ventilation. Okay, so just keep that in mind, because you'll see that like different parts of the lung are higher in perfusion, whereas some are lower in perfusion, some are higher in ventilation, whereas some are lower in ventilation. Just keep that in mind. So the base has relatively more perfusion than ventilation, so low VQ. And just remember, VQ is a fraction at the end of the day, right? So if anything, it's going to be in regards to the numerator, which is ventilation. So if something has low ventilation but has more perfusion, you're going to have a low VQ because V is on top. So this gradient explains oxygenation differences and why pulmonary embolisms create dead space, ventilation without perfusion. And this framework sets up pretty much everything we'll discuss about VQ mismatching. All right, so this slide is basically just all about spatial physiology, so how gravity shapes gas exchange. So in the upright position, both ventilation and perfusion increase towards the base of the lung, but perfusion increases more steeply than ventilation. That's the key detail here. Why? Because gravity pulls blood downward more dramatically than it affects airflow. Blood is heavy, air is compressible. So the apex has relatively low perfusion compared to ventilation, high VQ, and the base has relatively high perfusion relative to ventilation. Okay, so at the apex we have low perfusion, and then at the base we have high perfusion. But I like to think of it in terms of VQ, because then you have this really handy dandy mnemonic, which is high in the sky, low down low. So high VQ at the apex of the lung, low VQ at the base of the lung. And then on exam day, just remember what VQ means and you should be okay. So yeah, this gradient explains why the apex tends to have higher PO2 and lower PCO2, and the base is the opposite. So now switch to supine, the gravitational gradient flattens. Distribution becomes more uniform. That matters clinically, so you want to be thinking ICU positioning, unilateral disease, cysts, as shown in the diagram. Position changes, perfusion patterns. Okay, so when in doubt, use that high in the sky, low down low, and use VQ as your guide. Dalton's law is simple but powerful, so partial pressures equal fraction times total pressure. The fraction of oxygen in the air is about 21%, so what changes at altitude is total atmospheric pressure. As altitude increases, atmospheric pressure drops. That means PO2 drops, even though the percentage of oxygen stays the same. Lower alveolar PO2 leads to lower arterial PO2. That's hypoxemia. Now, here's the integration. Decreased PO2 stimulates peripheral chemoreceptors in the carotid bodies. That triggers hyperventilation. Hyperventilation decreases CO2, which raises your pH, which will then cause respiratory alkalosis. So, altitude exposure is not just a lung problem, it's a ventilatory and acid-base problem. So, if you understand Dalton's law, you understand why when someone starts to accumulate to higher altitudes, it always begins with hyperventilation. Okay, so now we're going to formalize what we previewed earlier. So, obstructive disease is defined by reduced airflow, specifically reduced ability to exhale quickly. FEV1 drops significantly because narrowed airways limit expiratory flow. FVC may be normal or reduced. The key is that FEV1 falls more than FVC. So, the FEV1 to FVC ratio decreases. That ratio is the defining feature here. So compliance increases in obstructive diseases, especially in emphysema, because elastic recoil is lost. Residual volume increases due to air trapping, so total lung capacity may increase because the lung becomes hyperinflated. So think mechanistically. If your airway is narrowing, you're going to get prolonged expiration, you're going to get air trapping, you're going to get increased residual volume, you're going to get increased total lung capacity. And so the common causes of this would be COPD, asthma, or bronchiectasis. So if the FEV1 to FVC ratio is low, you want to be thinking obstruction first. Okay, so the restrictive disease is fundamentally different. So here the problem is not airflow limitation, it's reduced lung expansion. So FEV1 decreases because total lung volume is reduced. FVC also decreases, often proportionally. Because both drop, the FEV1 to FVC ratio is normal or even slightly elevated. So compliance decreases, lungs are stiff, TLC decreases, that's the defining feature. Okay, so think pulmonary fibrosis. That's the example they're always going to use for this. Scarring of the interstitium reduces distensibility, and mechanistically, you're basically having a stiff lung, which will lead to low volume, which will obviously cause low total lung capacity, or TLC, and that's going to preserve your ratio of FEV1 to FVC. So, exam tip, if the ratio is normal, but the volume is low, that's going to be your sign that it's a restrictive disease. And an easy way you can remember the compliance between the two of these is, if you're restricting something, you're not being very compliant. So this one has low compliance. Whereas obstructive has higher compliance. But restrictive, for me at least, is a word that means to, resist something a little bit more than obstruction. So that's the way I remember that. Resistance is the one that has the low compliance. But again, you can just think through these mechanistically and make it make sense in your head. Okay, so oxygen is transported primarily bound to hemoglobin. Dissolved oxygen is minimal. So this is critical. Oxygen content depends more on hemoglobin concentration than on partial pressure of oxygen. If someone has anemia, their PO2 may be normal, but oxygen content is reduced because there's less hemoglobin to carry that oxygen. So saturation and content are different concepts. Okay, so this is why carbon monoxide poisoning is actually quite dangerous. It reduces the availability of binding sites without necessarily changing PO2. So always distinguish between partial pressure and oxygen content. Okay, so now we're going to get into the oxyhemoglobin curve. And this guy is going to show up all over the place, so get familiar with him. So the right shift represents decreased affinity of hemoglobin for oxygen, meaning hemoglobin does not want oxygen bound to it. Okay? What that means is that oxygen is released more easily into tissues, right? If hemoglobin has a weaker hold on oxygen, that means more oxygen delivery will take place. So a right shift will occur with increased carbon dioxide, lower pH, or increased H ions, those are saying the same things, increased temperature, or increased 2,3-bisphosphoglycerate. This is the Bohr effect in action. So exercise produces all of these conditions, which makes physiological sense. Working tissues need oxygen unloaded efficiently. So accumulating to a certain altitude increases 2,3-bisphosphoglycerate. That shifts the curve to the right to improve oxygen delivery in low PO2 environments. The left shift is just the opposite of a right shift. It's going to be increased affinity. So that's going to improve loading in the lungs, but impairs unloading in the tissues. So the curve isn't abstract. It's a delivery optimization system. And you're normally going to be using this to make sense of some vignettes that are going to throw a whole essay at you. So get familiar with this. It's your friend, because a lot of the times they will just throw one of the buzzwords out there like increased CO2 or lower pH or increased temperature or increased 2,3-bisphosphoglycerate. And they're going to want to ask you, which direction does the curve shift? That's about it. All right, so carbon dioxide is transported primarily as bicarbonate. It's not dissolved. So inside red blood cells, CO2 combines with water via carbonic anhydrase to form carbonic acid. That disassociates into bicarbonate and hydrogen ions. Bicarbonate exits the red blood cells in exchange for chloride, and this is called the chloride shift. So hemoglobin buffers the hydrogen ions. In the lungs, the reaction reverses. Bicarbonate re-enters the red blood cells, combines with H+ to form carbonic acid, which becomes CO2 and water. CO2 is then exhaled. So a smaller fraction binds directly to hemoglobin as carbaminohemoglobin. Okay, so CO2 transport is tightly linked to acid-base physiology, and this is why respiratory disorders affect pH so directly. So now we're getting on to neural centers of breathing. So breathing rhythm is generated in the medulla. The dorsal respiratory group controls basic inspiratory rhythm. The ventral respiratory group is recruited during forced breathing. The pre-Botzinger complex acts as a rhythm generator. Essentially, it is the pacemaker of respiration, okay? The pneumotaxic center in the pons modulates inspiration duration. It prevents overinflation by shortening inspiratory time. So damage to these centers can produce predictable breathing abnormalities. If you just know what they do, you can predict what the effects of some abnormality would be in that given region. So the respiratory pattern is centrally generated and then modified by sensory input. Okay, so now we're moving on to chemoreceptors. There are two major chemoreceptor systems. You're going to have peripheral chemoreceptors, and those are primarily in the carotid bodies, and they respond to decreased PO2, okay? Then you're going to have central chemoreceptors, and they're going to respond to increased CO2, but indirectly via changes in cerebral spinal fluid pH, okay? So CO2 diffuses across the blood-brain barrier, forms carbonic acid in the cerebral spinal fluid. That will then lower the pH, and that will stimulate ventilation. Central chemoreceptors are the primary drivers of ventilation under normal conditions. Altitude primarily stimulates peripheral chemoreceptors because PO2 will drop. In chronic CO2 retention, like COPD, central chemoreceptors will then adapt, and peripheral drive becomes more important. This distinction is really clinically relevant because a lot of times you'll given scenarios where people have adapted to, high altitude environments, or have lived with COPD for a long time, and they'll ask them, or the question will ask, due to living with COPD for such a long amount of time, what is the primary driver of inspiration in this patient, And literally all they're getting at is, okay, do you know the fun fact that the peripheral system becomes more dominant when you have chronic CO2 retention? Okay, so respiration under stress, or just exercise, right? So during exercise, tidal volume increases first, then respiratory rate increases. Alveolar ventilation increases dramatically, up to about 30-fold, and cardiac output can increase up to 6-fold. So ventilation increases proportionally to metabolic demand initially. PaCO2 remains near normal because ventilation matches CO2 production, and at the anaerobic threshold, lactate accumulates. Hydrogen ions increase, ventilation increases disproportionately to compensate lowering PaCO2. So, this is why intense exercise causes respiratory alkalosis. So, respiratory physiology is coordinated cardiovascular and respiratory adaptation. It's not just random hyperventilation to poison your body. It is all for a purpose. So now we're getting into the anaerobic threshold. This slide basically just represents the moment physiology shifts gears. At low intensity exercise, metabolism is primarily aerobic. Fat is the dominant substrate, lactate levels remain low. As work intensity increases, carbohydrate metabolism increases. Eventually, oxygen delivery can no longer fully meet metabolic demand. That's the anaerobic threshold. At this point, lactate begins to accumulate. Lactate itself isn't the villain here. Hydrogen ions are. So the rise in hydrogen ions will then lower the pH, and that stimulates ventilation. Ventilation now increases disproportionately compared to oxygen consumption. So PaCO2 actually drops because hyperventilation exceeds CO2 production. So, anaerobic threshold is identified by rising lactate, disproportionate increase in minute ventilation, and decreasing PaCO2. This is a predictable physiologic transition, and it ties directly into the acid-base balance. So, with altitude adaptation, altitude is basically a stress test for oxygen delivery. So, step one, you're going to have decreased PO2. That stimulates peripheral chemoreceptors, which will then cause hyperventilation, which will then cause decreased PaCO2, which will then cause respiratory alkalosis. Little side note here. A lot of these things in CVRESP are flowcharts. A lot of this is cause and effect, call and response, right? So I recommend kind of writing out these flowcharts so you get really used to seeing these words next to each other. And so maybe on exam day, you can kind of very quickly jot down a lot of these flowcharts, so you have to think less on vignettes. But anyway, so alkalosis suppresses ventilation via central chemoreceptors. So the body adapts. The kidneys compensate by excreting bicarb, so that will then lower pH back toward normal and allow ventilation to remain elevated. So over days to weeks, 2-3 BPG increases. That will then cause a right shift on the oxyhemoglobin curve, and that will cause improved oxygen unloading. EPO will also increase. And remember, going back to our hematopoiesis discussion, EPO is that erythropoietin. And that's going to cause increased red blood cell production. You're going to get polycythemia, and that will increase oxygen carrying capacity. So the acclimation to high altitude occurs in phases. So the immediate effect is going to be hyperventilation. The intermediate effect will be renal compensation, a little bit more long term. And then the long term will be the hematologic adaptation. So that's going to be your erythropoietin production. And actually, erythropoietin is what athletes use when we talk about blood doping. They basically inject themselves with a lot of erythropoietin to produce a ton of blood cells artificially, not while actually living at altitude, which is actually legal. You can just train at altitude to increase your EPO levels artificially. But they do decrease pretty dramatically over a couple of days, I believe. Which is why most people opt to do it illegally, so they can do it the day before a race or something. But anyway, so that's blood doping. All right, so decompression sickness. This is Henry's law in action. So at high pressure, like underwater, nitrogen dissolves in blood and tissues. That amount dissolved is proportional to pressure. So if ascent is slow, nitrogen gradually diffuses out and is exhaled. If ascent is very rapid, pressure will drop quickly, dissolved nitrogen will form bubbles, those bubbles obstruct vessels, they will cause ischemia, and trigger inflammatory cascades. So symptoms range from joint pain to neurologic deficits. So mechanistically, high pressure, increased dissolved nitrogen. So rapid decompression will cause gas bubbles. This is not oxygen toxicity, it's nitrogen physics. So understanding Henry's law explains the entire condition here. This is almost always tested as just a clinical correlation of how does this happen and why does this happen. All right, so this is going to be a pretty short slide here because this is just know these values, okay? Because these will show up in vignettes all the freaking time. And the less time you're thinking about is this number right or is it wrong or is this normal, is it not, the better, okay? So this must be automatic. All right, I have the guy praying in the bottom right here because, oh, yay, yippee, more stuff to memorize. But don't worry, we're almost there. So pH should always be 7.4. PaCO2 should be about 40, and H in bicarb or HCO3 should be about 24. Okay, so think of them as a balanced equation. This is the Henderson-Hasselbalch equation linking bicarbonate and CO2. Bicarbonate is the metabolic component. CO2 is the respiratory component, right? Bicarb deals with kidney stuff. Carbon dioxide deals with lung stuff. The ratio of bicarb to PaCO2 determines pH, okay? If you think of these as your normal anchors, you can pretty much tackle any of these vignettes. Okay, so respiratory versus metabolic compensation. Okay, here's the fastest way to approach this. So step 1, look at the pH. Is it acidemia or alkalemia? Step 2, identify what tracks with pH. Okay, so first, comparing it to our base of 7.4. If it's higher than 7.4, it's going to be alkalemia. If it's below 7.4, it's going to be acidemia. Then you're going to identify what's tracking with the pH, right? Are we going to have elevated CO2 levels that are causing that low pH? Or are we going to have really low bicarb levels that are causing that really low pH? So now, compensation. So in acute respiratory disorder, pH changes about 0.08 per 10 millimeters of mercury carbon dioxide change. With chronic respiratory disorders, kidneys compensate. So pH changes only about 0.03 per 10 millimeters mercury carbon dioxide. This distinction helps you determine acuity. So an example, if PCO2 rises from 40 to 60 and pH drops sharply, that's acute. If pH drop is a little bit milder, it's chronic with compensation. So compensation never overreacts. If pH overshoots, you want to be thinking mixed disorder. Okay, so the anion gap helps you classify metabolic acidosis. So the anion gap is equal to sodium minus chloride plus bicarb, and the normal range is about 8 to 12. If the gap is elevated, unmeasured anions are present. So classic causes are going to be given in this mnemonic: cat mud piles, which is carbon monoxide, alcoholic ketoacidosis, toxins like menthol, uremia, DKA, etc. So high anion gap metabolic acidosis means bicarbonate is being consumed, buffering an acid. Normal anion gap acidosis, also called hyperchloremic acidosis, occurs when bicarbonate is lost and chloride rises proportionally. Aspirin overdose is high yield, so early you're going to get respiratory alkalosis, so hyperventilation from medullary system, but then it's later going to become metabolic acidosis, which will be organic acid accumulation. So basically, this one's a little bit tricky. This is the one they love to kind of throw in as a curveball in exams because you learn alkalosis and acidosis disorders as very, not necessarily black and white, but very easy to distinguish from one another. But they love to throw the aspirin one in there because it starts out as a respiratory alkalosis, but then it ends as a metabolic acidosis. So just keep that in mind. All right, so now we are finally switching gears to pharmacology. So all preganglionic neurons in the autonomic nervous system release acetylcholine onto nicotinic receptors. Parasympathetic postganglionic neurons release acetylcholine onto muscarinic receptors. Sympathetic postganglionic neurons usually release norepinephrine. Some exceptions are sweat glands, which are sympathetic but acetylcholine mediated. The adrenal medulla acts like a modified sympathetic ganglion. It releases epinephrine and norepinephrine into circulation. Understanding the wiring will help you predict drug effects, which we will get into here in a second. But the basic thing I want you to take away here is that parasympathetic act on muscarinic receptors, sympathetic act on adrenergic receptors, and so I think this diagram on the right here is really solid. I recommend giving it a watch. I also recommend this is one to just look up a quick YouTube video on if the receptor stuff is still giving you trouble, because this will be a recurring theme in almost every system because drugs are everywhere. So with that said, let's get to it. Okay, so when you take a prescription drug, chances are they're going to be acting on one of the four of these receptors, okay? There are also muscarinic receptors, but these are the highest yield receptors that they're going to want you to know. So alpha-1 receptors cause vasoconstriction, and this will increase systemic vascular resistance. Alpha-2 receptors are presynaptic, and they inhibit norepinephrine release. They act as a brake. Beta-1 receptors are primarily cardiac, increased heart rate and contractility. And beta-2 receptors cause bronchodilation and some vasodilation in skeletal muscle. This receptor map explains future pharmacology. So basically, just remember beta-1 increases cardiac output, beta-2 decreases airway resistance. Those are big ones. I really recommend just writing these out and writing what they are in charge of, because once you know that, it's really easy to figure out, oh, this activates a beta-2 receptor. Okay, well then I know this will definitely help with breathing because it's going to cause bronchodilation, right? So knowing all those fine details is unfortunately very, very important. So I recommend just getting a whiteboard or a piece of paper and writing this out and just looking at it, putting it on some flashcards. This is very, very high yield. Okay, before we dive into drugs, we're almost there. I promise. I know everybody's crazy for the drugs. We're gonna get into the baroreceptor reflex just because it deals with blood pressure, and a lot of the drugs that we discuss have to do with blood pressure. So this is your body's way of dealing with it first before taking any sort of drugs. So the baroreceptor reflex is rapid blood pressure regulation. If blood pressure drops, baroreceptor stretch decreases, afferent firing via the cranial nerve 9 and 10 will decrease, sympathetic output will then start to increase, and parasympathetic output will decrease. So the result here, if we're increasing sympathetic output, aka increasing heart rate, you're going to be acting on that beta-1 receptor, right? Increased heart rate and contractility. You're also going to be using alpha-1 receptors, which will cause that vasoconstriction. Okay, so vasoconstriction increases preload for your heart. So cardiac output increases, total peripheral resistance increases, mean arterial pressure will return toward normal. So if blood pressure rises, the opposite happens. This reflex explains reflex tachycardia with vasodilators like nitroglycerin. All right, so this one, again, I really recommend just using flashcards for this. listening to me yap about this will only help those of you who are already familiar with these. So I really, really, really recommend just using Anki or Quizlet to throw these on a quick little study deck and cranking through them. So the drug overview. So dobutamine is a beta-1 selective agent, so it increases contractility of the heart. It's used in cardiogenic shock to improve cardiac output. Amlodipine is a calcium channel blocker that acts primarily on vascular smooth muscle, causing arteriolar dilation and lowering afterload. Verapamil is more cardiac sensitive. It decreases heart rate and contractility. Then you have nitroglycerin, which will increase cGMP via nitric oxide. It causes venodilation more than arterial dilation. That reduces preload. Reflex tachycardia may occur via the baroreceptor reflex using this. Digoxin inhibits sodium-potassium ATPase. That increases intracellular sodium. That reduces the sodium-calcium exchanger activity. So then calcium accumulates intracellularly, and then that will cause contractility to proportionally increase. It also increases vagal tone, so suppressing AV node conduction. And then each of these drugs maps directly onto the receptor and reflects the physiology we just discussed associated with each receptor. So again, pharmacology, I kind of like to treat it like a board game, learn the receptors as the players, and then the different drugs are like modifiers on those players, okay? All right, so we have made it to the end of week 3, so it's time for our rapid fire week 3 review. So again, I'm just going to quickly yap through all of these and just use it as a way to, hey, do I know that? Hey, do I not know that? Okay, do I need to touch up on this? So here we go. Deep inhale, once more with feeling. Let's do it. So, starting with volumes. Spirometry does not measure residual volume. That single fact explains why it cannot directly measure TLC or FRC either. Because both include residual volume. If residual volume increases, think air trapping. That immediately points you towards obstructive disease, increased RV, increased TLC, decreased FEV1 to FVC ratio. That's your obstructive pattern. Restrictive disease is the opposite logic. The problem isn't getting air out, it's getting air in, so TLC decreases. FEV1 and FVC both fall, but the ratio stays normal or even increases. So now we have compliance. Obstructive disease, especially emphysema, has high compliance. The lungs inflate easily but recoil poorly. Restrictive disease has low compliance, stiff lungs, and resist inflation. That's not just a number, that's the mechanical work of breathing. Laplace law explains why surfactant is life-saving. Small alveoli would collapse without it because pressure equals 2T over R. If you reduce surface tension, you reduce collapsing pressure. So the connection here is premature infants without sufficient surfactant develop respiratory distress syndrome because their alveoli collapse. Then resistance. Resistance is inversely proportional to the radius to the fourth power. That means small airway narrowing causes massive increases in resistance. Asthma is dangerous not because the airway closes completely, but because even mild narrowing dramatically increases work of breathing. Okay, so all of this is architecture. If you understand the structure, pathology becomes predictable. All right, now we shift from mechanics to gas exchange and control. So pulmonary vascular resistance follows a U-shaped curve, lowest at FRC, overinflate the lungs, and you compress alveoli capillaries, underinflate them, and extra-alveolar vessels collapse. That's why extremes of lung volume impair perfusion. Ventilation, perfusion relationships are gravity-dependent. The apex has a high VQ, remember high in the sky, relatively more ventilation than perfusion. The base has low VQ, low down low, relatively more perfusion than ventilation. Dead space is ventilation without perfusion, like pulmonary embolism. Shunt is the perfusion without ventilation, like severe pneumonia. The oxygen dissociation curve shifts right with increased CO2, increased acid, increased temperature, and increased 2,3 BPG. That right shift improves unloading to tissues, which is exactly what happens during exercise and altitude adaptation. Carbon dioxide transport is mostly bicarbonate. That means respiratory disorders directly influence acid-base status. Finally, control of breathing. Central chemoreceptors respond primarily to CO2 via cerebral spinal fluid pH. Peripheral chemoreceptors respond to low PO2. Under normal conditions, CO2 is the dominant driver. At altitude, low PO2 becomes more important. Everything here links ventilation to chemistry. And so finally, we have the slide that will integrate respiratory physiology with acid-base and pharmacology. At altitude, decreased PO2 stimulates hyperventilation. Hyperventilation lowers PaCO2, producing respiratory alkalosis. The kidneys compensate by excreting bicarbonate, and over time, 2,3 BPG increases to improve oxygen unloading. An acid-base analysis always start with pH, then determine whether CO2 or bicarbonate is the thing that is causing that pH abnormality. Respiratory disorders follow PaCO2, metabolic disorders follow bicarbonate. Normal anchors are pH of a 7.4, CO2 of 40, and a bicarb of 24. Compensation never overshoots. If it does, it's a mixed disorder. Aspirin is the classic mixed example that will probably show up on your vignette. And remember, respiratory alkalosis plus metabolic acidosis. Then autonomics. Alpha 1 causes vasoconstriction, beta 1 causes heart rate and contractility, beta 2 bronchodilates, and we didn't really get into muscarinics, but I do recommend looking them up as well. But M2, muscarinic, remember, parasympathetic is what you want to be associating with muscarinic receptors, whereas adrenergic is what we want to be associating with sympathetic stuff. So if you think of parasympathetic as rest and digest, what do you think the muscarinic receptors will do? Probably things to do with the parasympathetic nervous system. So M2 actually slows down the heart, okay? So those receptors explain both physiology and drug actions. Dobutamine stimulates beta 1 to increase contractility, useful in cardiogenic shock. Amlodipine dilates arterioles, reducing afterload. Verapamil slows AV conduction. Nitroglycerin increases cGMP, causing venodilation and potentially reflex tachycardia. Digoxin increases intracellular calcium to improve contractility and enhances vagal tone at the AV node. And so basically the theme of week 3 is integration here. Ventilation affects CO2, CO2 affects pH, pH affects hemoglobin affinity, autonomic tone affects heart rate and vascular resistance, and drugs manipulate those same pathways. So if you can explain these relationships without memorizing them, you're kicking ass. Okay, so that does it for CVRESP. I know this one kind of came and went, but for those of you who are watching, I hope you find it useful. I hope this is able to net you a couple extra points on your next big exam. Once again, thank you for stopping by MooseMed, where we take medicine by the horns, but for all intents and purposes, moose have antlers. Okay, folks, I will see you later. Good luck, keep studying, and I will see you in the next one.